Thanks everybody for coming, to those who are here, and thanks, and those who are joining us online. So to the meeting today, we're happy to welcome Dr. Matthew Bluett Duncan. Dr. Bluett Duncan is a psychologist from University, and he's been involved in the conception study. So his research focuses on long-term neurodevelopmental impact of in utero exposures to maternal medication, specifically looking at methodology. So looking at the development and utilization of research tools, methods, and frameworks that can enhance the vigilance practices to prevent fetal harm and allow women and healthcare professionals to make informed choices. As I said, his background is in developmental psychology, and he's conducted a number of studies with prospective birth cohorts across different cultural settings globally. So he's going to speak to us now looking at long-term follow-up of neurodevelopmental outcomes following in utero exposure to potential terrestrials, I think mainly medication. So I think he'll do the presentation and then there'll be time for questions afterwards. Thanks very much.
Great. Hi, everyone. Most people are online, so I'm not quite sure where to look either, but we'll do our best. Thank you very much for coming to listen to me, and thank you very much, Ushma and Emma, for having me here. I'll just start by just going to move. There we go. Just a little bit about me, and Emma's already kind of introduced who I am. But I'm here to do some work with Ushma and with the Bluett team to look at potential collaborative work in the future, very much kind of a scoping exercise. We've had some really good meetings and kind of had a whole load of information, which has been really, really useful. I've got the processing for a little while. My background, as Emma said, is in psychology. I started out working as a research assistant on prospective birth cohorts in the UK, looking at psychosocial predictors of cognitive outcomes, behavioural outcomes in children. And from there, I went to do my PhD as part of the Wirral study in the UK and its sister study in Bangalore in India. And again, we were looking at the impact of perinatal mental health on infant development, but also doing quite a lot of work on cross-cultural research methods as well, looking at how different cultural experiences influences how participants respond to questionnaires, and if it's something we need to take into account when we're doing cross-cultural research. From that point, I moved on to work in neurobehavioral teratology, which is effectively looking at how different medication or different exposures during pregnancy can alter fetal development and result in different neurodevelopmental deficits or impacts. I've been working in that for the last couple of years as a postdoc at the University of Manchester, and as Emma said, working on the IMI conception study. So I'll just quickly explain what that is. So the conception study is a public-private partnership. It's funded by the EU Innovative Medicines Initiative, co-led by Novartis and the University Medical Centre in Utrecht. The idea of the study is to bring together colleagues from across different fields, so academia, pharmaceutical companies, regulators, public health bodies, and really to bring together all the expertise in order to try and develop an ecosystem or improve the ecosystem around the EU for collecting data regarding medication exposure during pregnancy. But not only that, also then ensuring that we can make that data available to the right people, including patients and healthcare professionals and any other advocacy groups. So it's primarily methodological in nature. So rather than collecting lots and lots of data, we're kind of more involved in designing different systems, which is what I'm going to talk a little bit about today. So that's just the overall structure of the study. I won't cover all that. It's just to say that it's quite big, and we formed just a little part of it. So I'm part of work package 2, and that the kind of the primary focus of the work we're doing, work package 2, is looking at developing primary data collection systems and improving primary data collection for neurodevelopmental longitudinal outcomes. This is kind of the makeup of the WP2 Core Team. There are other members of the team as well, but this is the group I work most closely with. So Dr. Laura Yates, who some of you probably do know, is now back at Newcastle University NHS Trust, but she is a co-lead on this work package. Dr. Rebecca Bromley, who's at the University of Manchester with me, myself, Dr. Jonathan Richardson, who works at the UK Teratology Information Service, Dr. Dave Lewis, who is, I'm not entirely sure what all those letters mean, but basically he's the pharmacovigilance head in the EU for Novartis, and Amalia Alex as well, who also works with Dave in pharmacovigilance at Novartis. And all those have inputted into the work I'm going to discuss today. So today I'm just going to have a look at a couple of the things we're doing in Work Package 2, not everything by any means. Again, so the overall aim of the work package is to improve methodologies and improve methodological approaches for collecting primary data in longitudinal outcomes. First, I'm going to look at an expert working group that we convened, which we convened to look at reaching a consensus on recommendations for optimizing neurodevelopmental outcome research in pharmacovigilance. And then I'm going to have a little look at the lifetime framework for neurodevelopmental outcomes, which is the system of follow-up we designed to work in the UK and in the EU to put into practice some of those recommendations. And I'll touch on the pilot work we're doing with that system. I've also got here Teratopen and the Conception app. I'm not going to talk about them today because I don't think we've got time to cover everything, but I have included video links at the end of the presentation if you want to kind of follow that up, with Teratopen being a network which is really focused on improving collaboration between clinical geneticists around the world who are looking at deep phenotyping different exposures. And the Conception app being a very useful tool, actually, which is aiming to try and standardize safety data, collection of safety data following exposures during pregnancy. So there are a couple of videos at the end which you can look at if you want to follow it up a little bit more. And I guess the main question, I guess, to think about if you're interested in thinking about it as I'm going through is, again, rather than thinking, I'm not coming over here saying this is the system we're using, everyone should use it. It's more hopefully to present some principles of follow-up of neurodevelopmental outcomes. And what we've been discussing over the past week and what we've been thinking about is how do we enact these principles in different settings. So although the systems themselves may look very different based on the different needs and different infrastructure in different places, hopefully the principles are something that will help inform our decision making. So feel free to kind of take what you want from the principles without necessarily having to worry too much about the actual system itself. So I'll talk about the expert consensus project first, as that's kind of guided a lot of the work we did. The aim of this project was to achieve consensus regarding an optimal approach to neurodevelopmental follow-up in pregnancy pharmacovigilance. And to do this, we brought together 24 experts from different backgrounds, different experiences and professions, who've worked with a range of different types of exposures, whether it's medication, environmental, recreational, really to get as broader input as we could. And then we used a Delphi approach to then try and generate some consensus on how do we design studies, how do we report results, how do we communicate results, and follow the process. I think it's a fairly standard Delphi process, I think, whereby we had round one where we kind of just sent out a bunch of open questions to say, what are your thoughts on this? What are your thoughts on this? What are your thoughts on this? Got a lot of responses back, and then use that to then kind of come up with a set of specific statements to say, well, here's a statement about a certain design feature. Do you agree or do you disagree that this is something that would be useful? And then from that, we then had a virtual discussion together, which really looked at to address, first of all, to discuss areas where we had reached consensus, but also to look at specifically the areas where consensus hadn't been reached and to kind of try and work out what the different issues were. And all of that was then kind of developed into an expert consensus document, which included 11 key recommendations for neurodevelopmental follow-up. And I'm just going to cover just a couple of the key ones that came out of that. So the first one kind of seems very obvious, but is that neurodevelopmental outcomes should be integral to pregnancy pharmacovigilance. And it's not obviously, it's a very simple statement. But again, if you're kind of aware of how limited data collection is in this area, then you'd probably be familiar that it's a statement that needs to be made, because again, it's very rare. It's a global problem. People don't tend to follow up neurodevelopmental outcomes very often. So that was kind of key to us. It's important to follow it up, because we now know we now know that the fetal brain can be impacted by different estrogens. Not all medications or all exposures, definitely, but there is the potential for altered fetal development. So it's important that we look at this as a priority. And then, okay, so then we asked, well, if it's a priority, then how do we choose which medications to look at? How do we choose which ones to be routinely followed up? And the ideal answer is, well, we follow up everything. That would be great if we could follow every single medication up, but we know, of course, that would require a lot of time, a lot of money, a lot of resource, which again just aren't available. So how then do we think about it pragmatically? How do we prioritize the different medications that we should look at? So we came up with agreed on a few different principles. So the first is that there should be mechanistic plausibility. So, for example, if a drug is CNS acting, we know that has a higher potential to impact the brain. So that would be something that would take priority. Is there evidence of risk for physical development, either in preliminary preclinical studies or in human studies? Because again, we know it's not obvious, it's not kind of a certain relationship, but we know that if there's a physical impact, there's more likely to be a neurodevelopmental impact as well. And then also, is there any preliminary evidence of impact on brain development? And that's particularly looking at preclinical studies, which again, I think we discussed preclinical studies are very useful. I think the consensus was you cannot make conclusive decisions regarding risk or safety based on preclinical work or animal studies, but they're very useful for generating signals and for informing us when we should perhaps look a little bit closer, and for dealing with things like confounding. Obviously, not just signal generation, they are very useful. And then finally, the final consideration was, are the medications widely used in women of childbearing potential? And so those are kind of the four key things. And it's not a case of all those have to be met, but more a case of, if one of those considerations is relevant, then we recommend that regulators make it mandatory that neurodevelopmental follow-up is in place. And if there's more than one, so there's two or more that are in evidence, then we recommend that it will be research will be conducted as a priority. So again, just emphasizing the importance of it. So we also looked at what if we're going to assess neurodevelopment, what do we assess? What's the most important thing is to assess? So we asked experts to agree on a core set of neurodevelopmental domains that should be investigated so that we can fully understand the risk and safety profile. So we identified a wide range of these functions, because neurodevelopment covers quite a wide range of functions in the brain. But the key ones that got pulled out were cognitive development, motor development, behavioral and emotional development, clinical disorders, and then educational outcomes. And there was very much an emphasis that all these outcomes, although they're linked together, and you can see links between obviously cognition and educational outcomes. And if someone has an ASD diagnosis, they're more likely to have an intellectual disability as well. However, although there is a link there, you also have them acting independently. So we can't say for sure, for example, we've assessed cognitive development and nothing happened there, so therefore we know medication is safe. The consensus was very much that each area would need to be assessed across a number of studies before you could be satisfied that there was no impact on neurodevelopment. And then we also looked at how we measure these things and what's the optimal approach to measuring these domains. So the ideal approach would be a standardized direct assessment, so something where you're working very detailed, where you're working with the child directly, and it's conducted by either a researcher or a clinician who's been trained to a standardized and reliable manner, where they're blind to the exposure that the child has been exposed to, again, to try and reduce bias. and then that this should be addressed across the whole cohort as well, not with just specific children. And although we say that standardized direct assessments are the gold standard, there was also a consensus that parent report questionnaires are also very useful. At a very practical level, because they generally take a lot less time and aren't expensive, but also parent reports do tend to tap into things that direct assessments can't do, particularly in terms of social behaviour, where again you might not get a true reflection of that in a clinical setting. So important to have kind of a triangulation of data in that respect. So this is just to summarize. So there were more recommendations. So our conclusion was that we do need an improved focus on neurodevelopmental outcomes in pregnancy pharmacovigilance. And we presented 11 recommendations, which we hoped that would highlight the importance of neurodevelopmental follow-up, would improve the quality of the data that we get when we do it, but also lead to a faster accumulation of data. So there's less delay between medication being utilized and knowing whether that medication is safe or not. And as I said, we know a lot of the recommendations are quite, if you take all the recommendations at once, you've had to probably create the most amazing study ever designed, and it will cost more money than you can imagine. We know we're setting a high standard. What we're saying is these recommendations should be met by a triangulation of different studies across a range of approaches. And ideally, if this is done, then we will be able to reduce fetal risk and reduce the risk of babies being exposed to potential pathogens, but also improve maternal confidence in the medications that they're taking, which is important because again, not having one of the hidden, I guess the more hidden issue of having limited information is obviously it's a risk to the fetus, but also if you don't know if the medication is safe or not, then we know that leads to less adherence to medication, which also can be dangerous for the mother, but also dangerous for the child as well. So having this information kind of helps on both sides. So now I just want to have a little look at the lifetime framework. So this is a framework we're kind of piloting now in the EU. So we're going to have a look at how we've enacted some of the recommendations, but also consider how we've had to find a balance between the optimal design and the practical constraints of the real world. So our overall aim in developing the lifetime system was to develop a system to address limited routine collection of data regarding child health and neurodevelopment following in utero medication exposure. And this process was guided by the expert working group, but also by stakeholder consultation and engagement with patients and healthcare professionals. And so I've split the considerations I've got here into kind of two things. First being the research priorities, and second being the feasibility priorities. So it was important that we had a prospective design, that women were recruited during pregnancy wherever possible before they knew the outcome to reduce bias. It was important for us that we were able to do assessments during infancy, because we know a lot of rapid development takes place during infancy, and a lot of the foundations of future development are built at that point. However, although infancy is very important, we also wanted to make sure we were following children up beyond that point, because the brain continues to develop throughout adolescence and into adulthood, and so really at a minimum we need to be following children into that older age childhood and adolescence, because again, as the brain matures, you may begin to see hidden deficits that weren't apparent when children were in infancy. And then as well, we wanted to make sure we covered the core developmental domains that I addressed earlier on. But then alongside that, we also wanted to make sure it was a system that worked for people. So we wanted this to be something that existing surveillance initiatives would use. So whether they're teratology information services, pregnancy or kind of disease-specific registries, drug-specific registries, or any kind of existing pharmacovigilance, we wanted to make sure this was something where we didn't have to start from scratch, but it's something that could be added on to what was already being done to make it as practical as possible. And in order to do that, we consulted with a few of these different potential collaborating groups, and kind of key things that were raised as important. First, it's cost effective. So we don't want to limit its use by kind of giving someone a system or use a system, but it costs this much money. People, oh no, thank you. So we want to make it as cost effective as we can, but also efficient, kind of time efficient. So We don't want people to have to spend lots and lots of time on this work. If we can do something routine, which is relatively cheap and relatively time efficient, then obviously it's going to increase uptake. And also a lot of the groups that we're working with don't have any in-house neurodevelopmental expertise. And so again, we wanted a system that could run almost by itself, with some consultation from kind of the overseeing group, but without the need for daily input from a neurodevelopmental expert. And then also we wanted it to be standardized but flexible. So we wanted, wherever possible, to have a standardized approach, because again, if possible, we like to be able to combine data across different collaborating groups. But we're also aware that each pharmacovigilance initiative or group may have different requirements or different capacity to use the system. So we wanted to keep it flexible as well. So this is kind of what we came up with in the end. So this is the full system as it is. So our proposal was a standardized, cost-effective network for routine longitudinal follow-up that builds onto existing pregnancy pharmacovigilance initiatives, is sensitive to detect signals of risk in different exposures, and is valid across a range of exposures. So again, we want it to be as flexible as possible, not siloed into one particular exposure or type of exposure. So I'll just go through kind of each section here. So the first bit there I've highlighted, that's obviously the pre-birth stage. And generally speaking, most of the collaborating groups we'll be working with are already collecting data at this point anyway, so there's very little that we need to do at this point. We did define a set of minimum exposure variables that we wanted data collection systems to collect, with key variables such as dose of exposure, timing of exposure, gestational timing of exposure, duration of exposure, how long the exposure went on for, and also things like family history of neurodevelopmental disorders, which are very important for looking at neurodevelopmental outcomes in order to control for that additional confounding. But most existing systems don't collect that data because it doesn't have much of an impact on birth defects, which is where most people stop. So that's what we're looking at that point. At 6, 12, and 24 months, we are planning to send out the ages and stages questionnaire, as well as a set of kind of standardized health questions. And the ages and stages is just a parent report screening questionnaire, which covers kind of key developmental domains such as social development, communication, problem solving, and motor. And it takes 10 to 15 minutes to complete. Relatively straightforward, has lots of nice pictures to illustrate how to do it, and the mums can do it themselves. So we'd send that out 6, 12, and 24. And then as the child gets older, as you can see, the age intervals get a bit wider apart, again, reflecting the fact that development slows down, but is still ongoing. However, at this point, although development may slow down, it also becomes a bit more complex. And so we have, in order to kind of meet that need, we I guess curated a set of questionnaires that covered all the key developmental domains and kind of put it together in one set. And then that will be sent out ideally at 4, 7, and 10 years. And again, remember, this is the full system, but I think probably very few collaborating groups would use the whole thing. Again, the flexibility means people can say, oh, well, I only want to follow up 24 months, or I only want to follow up to 4 years, but I can't do all the assessment intervals, and that's all fine. It's just, people can use it as have capacity for it. And then as well, key to making it kind of accessible is that all the questionnaires are parent report questionnaires. And although that, again, isn't necessarily the gold standard we're looking for in terms of direct developmental assessment, the questionnaires we're using have all been validated, and we know they're sensitive, and they should be sensitive enough to detect a signal of risk. And the idea is that if we detect a signal of risk in a particular exposure, we either then got evidence to apply for more funding to do more in-depth assessments. So currently we're in the piloting phase. This is the prospective pilot. So we're doing a prospective and a retrospective pilot. In the prospective pilot, we're working with 3 different groups: the UK and Ireland Epilepsy and Pregnancy Register, the Lara Pharmacovigilance Research Centre, which is in the Netherlands, and then the Bergen and Oslo Epilepsy Research Group as well, which is in Norway. And the idea, really, the primary aim in this pilot is to see if it's a feasible system if it's acceptable to the collaborating groups, if it's acceptable to patients, and if there's any other issues in kind of infrastructural issues that we might need to work out as we go through. But we're also going to pilot as a secondary question, can we then, the data that we do get, can we bring it together and combine to answer a specific question regarding medications? And we're focusing primarily on anti-epileptic medications at this point, because again, that's generally what most of the data we have is in those groups. So the prospective pilot just covered up to 24 months. Unfortunately, no one wanted to give us a 10-year pilot, which you could probably understand. So we're piloting the system up to 24 months. But then we also conducted a retrospective pilot of the older age questionnaires. So again, for this, we wanted to see, is the questionnaire set acceptable to participants, and does it identify the expected risk in an already known teratogen? So are the questionnaires as sensitive as we think they are? And so I'm just going to talk a little bit about that study and give a few results as well. So we decided to use sodium valproate as our known teratogen because it has a very established pattern of risk. It's obviously a very effective anti-seizure medication and is also used for conditions such as bipolar and migraine. But although it's very effective, it also, as I said, has a very consistent evidence of teratogenic effects. So we do see increased risk of congenital malformations. We see a very distinct dysmorphic facial features. In terms of neurodevelopment, there's a significant reduction in IQ, which appears to be also kind of specifically affects language and verbal skills as well. And we also see increased risk of clinical disorders such as autistic spectrum disorders and ADHD diagnoses. And that's just in the general valproate exposed population. There is also, for those more severely impacted, there is now a diagnosis of fetal valproate spectrum disorder. And this is typically a more severe presentation and is generally diagnosed by a geneticist. However, data in this specific population is actually quite lacking. We have a lot of data in general valproate exposed population, but not in the FVSD population itself, which obviously you expect to see a similar pattern of results. However, we know that not all people exposed to valproate are susceptible to the effects. And so what we'd probably be seeing is a slightly diluted version or diluted impact in those wider populations. So it's important to look at the FVSD population specifically in order to understand how they develop as they get older, but also how can we support these individuals and how can we offer the right services. So I'm just going to present some of the results from this pilot that we did. So again, the primary aim was assessing the sensitivity of the questionnaires, but we also wanted to look at the older age phenotype as well. So it was a retrospective semi-cross-sectional design. It was entirely parent report. We had three groups of participants. We had those who were diagnosed with FVSD. We had those who were exposed to valproate but not diagnosed, and those who weren't exposed at all. And the age range was quite wide. Again, it's quite preliminary study, so we have, I think, the age range from 7 years to 37 years, with the mean age of around 18 years. But the questionnaires we used were all fairly age neutral, as far as we understood. And then the domains we looked at included cognitive development, academic functioning, psychosocial problems, clinical disorders, service utilization, and then sensory issues as well. And sensory issues aren't necessarily a part of lifetime, but they were raised as a particular issue for this population. So we included that for this study. So our primary outcome was cognitive development. So we used a measure called the PROMIS-PCF perceived cognitive function. And this is a parent report questionnaire of everyday cognitive functioning, which gives you a mean standard score of 50, and then gives cutoffs to represent different levels of impairment. So we found that those in the FVSD group were scoring significantly lower than any of the two groups. The mean overall score of the group was in the moderately impaired range, and a much higher proportion of children in the FVSD group were in the moderate or severely impaired range in terms of cognition. So about 14% were severely impaired and 43% were moderately impaired. We then asked parents about their children or young people's academic functioning. Overall, the FVSD group had lower ratings of academic competence, and this rating of academic competence was moderately and significantly associated with the cognition score as well. Again, indicating that the cognitive impairments we see in the questionnaire is having a very real impact on day-to-day life. And again, this impact, I think, is emphasised when we asked about formal educational support. About 83% of individuals in the FVSD group had a formal statement of support from school or from the local authority where they were, compared to 30%. I can't see there. Anyway, a much lower rate in the non-exposed group. So we also looked at behavioural and functional problems using the paediatric symptoms checklist. This gives you an overall psychosocial problem score, but then also splits it down into specific difficulties. So overall, children with FVSD scored had the highest psychosocial problem score. And again, the mean score was above the threshold for identifying children who were at risk for serious problems. Specifically, we saw that a lot of these psychosocial problems were found in internalising problems. So internalising problems being more anxiety symptoms or depressive symptoms. And this was much higher in the FVSD group. And the overall score, again, was above the cutoff for risk in this. We're also quite a lot of attention problems. And again, it was highest in the FVSD group, but at this point, the overall mean was below the overall cutoff for risk. Although there was still, you can see 55% of children or children or young people were at risk for attention problems. And this contrasts with externalizing problems, which refers to more conduct problems, aggressive behavior, which actually was lower in the FVSD group than the non-exposed group. And the mean was below the cutoff for risk. And again, that does follow the pattern of findings we'd expect to see in this population. We also just asked a very, very basic question, which of these kind of neurodevelopmental disorders has your child or young person been diagnosed with? And I think here you can see really stark differences. So in the light blue, we have diagnoses in the FVSD group, and the dark blue, the background rate in the general population in the UK. So I think autism or ASD is the most stark difference. You can see that 63% of individuals with FVSD have received an ASD diagnosis compared to about 1% in the general population. So you can see it's a huge, huge increase. And similarly, very high rates of intellectual disability, language disorder, sensory processing disorder, almost all of the neurodevelopmental disorders we asked about, with the exception of conduct disorder, which was about similar to the background rates and actually does fit in with the fact that we saw very low externalizing problems in the sample as well. So again, you can see a bit of validation between the different measures, but you can see the variety of challenges that these children have as they get older. And this is further emphasized, I think, by the service utilization in the group. So we asked, what services have you accessed or had to use as your child's been getting older? And again, very, very high rates, particularly in speech therapy. We saw about 88% of individuals had accessed speech therapy at some point, which does again concur as consistent with the finding that the verbal impairments are particularly seen in this group. But then also we saw very high rates of need pediatric care, occupational therapy, physiotherapy, and again, almost every service. So again, really just emphasizing the wide range of difficulties these individuals face. And of course, the burden that then places on themselves and on their families in terms of the time it takes to get to all of these different services, the money costs to use the services depending on what's on offer where you live, and also the societal cost as well is obviously quite large, bringing all these services into action. And then finally, we looked at sensory difficulties, and again, not part of a lifetime pilot, but it was something that had been raised by the family groups that we were consulting with as being an issue. And we did find quite significant levels of sensory difficulties, with just over 80% of parents of children with FVSD saying that they had significant challenges with sensory difficulties. And this is spread across a range of different challenges, which I think like noise and pain are the two highest. So about 75% of individuals with FVSD were either oversensitive or undersensitive to noise, and similar with pain, about 65% were undersensitive or oversensitive to pain. And again, this is something which has a real impact on daily life and your ability to participate in education and kind of social settings, in employment. So these kinds of things are really important to understand as these individuals are getting older. But also, they're things that can be addressed through strategies. So if a school or an employer is aware of these challenges and they're able to be trained in the strategies to manage some of these things, then it can make participation in society a lot easier for this group of individuals. So that's just kind of the general summary that we saw. I won't go into detail on that. It's kind of just covering everything that we've already talked about. And then this is just to conclude what we found. So obviously we were looking to see if the questionnaire set did identify the expected pattern of impairment in older children and adults with FVSD, and we found that it did. So we found very high levels of cognitive and intellectual impairment, which you'd expect to see. And we also saw, I think one of the things that's most interesting to pull out from the questionnaire about psychosocial problems is we saw very high internalizing problems and very low externalizing problems. And again, anecdotally and from clinical reports, from people working in a clinical setting, this is very much their experience that they have. So we're seeing the pattern that we expected, which is good news for our questionnaire. Additionally, as well, we saw that the questionnaire set was able to differentiate between 3 different levels of exposure. So we had the FVSD diagnosed group, we had the Valproate exposed but not diagnosed group, and then the non-exposed group. And really, for every scale and at every point, we saw quite a nice kind of step down or step up of scale scores that you would expect to see if the questionnaire was functioning as hoped. So kind of we concluded the older age questionnaire does appear to be valid and sensitive to traumatic effects. But we are going to work on some further validation of this as well. And we want to validate it against clinical assessments in individuals with FVSD, and that's some work we're going to be doing over the next year. And we also want to use the questionnaire in suspected tractogens with more subtle effects. So we know Valproate has a very large impact, but also is the questionnaire going to be sensitive to more subtle effects? So we're going to look at a few different medications, including topiramate, fingolimod, and mycophenolate, just to see if the questionnaire is going to detect those more subtle effects. So just to summarize, in terms of the pieces of work I covered today, so we had 24 experts from a wide range of professional and cultural backgrounds who developed a set of recommendations for optimizing the collection of neurodevelopmental outcomes following in utero exposure to medications. That paper has now kind of been submitted, so hopefully that will be available soon. And we've also developed and are piloting a framework for neurodevelopmental follow-up that can be utilized in existing pharmacovigilance initiatives to extend the work that they're doing. And so the questions we're thinking about, and I guess in the work with the conception study, but also in the discussion we've been having this week, is first of all, we still want to see how feasible is this framework in different settings across the EU. Secondly, is it feasible to develop a similar framework for routine surveillance of neurodevelopmental outcomes in the Western Cape or South Africa more broadly? And then if something like that is feasible, then how can such a system be developed and how do we start and what should it look like, etc. So again, if anyone has any answers to those questions, you're very welcome to contact me and tell me. You're very helpful. That's my email there, and those are the links to the other videos, including another presentation on the lifetime system. But yeah, thank you very much for listening. I shall finish there and I guess open up for any questions.
Yeah, that's great. Thanks very much. So we can see the Teams people. Okay, great. You filled that nicely. I can't see them on the screen. So I don't know if there's anyone in the room or on Teams who have any questions.
Thanks, Matthew, for a great presentation. It was fantastic. I was just curious, I'd be very keen if you could elaborate a bit more on the cultural bias aspects that you considered during this process.
Yeah, so I think so. A lot of the cultural bias work I've done was with my PhD. So it's slightly separate. But we were looking basically at whether, and it is relevant to this work, because all the work we're using is parent report questionnaires, so it's self-report questionnaires, where generally you're asked a question and you say, you know, how well is your child doing cognitively? You say, not very well, okay, great. And you and I might both answer that question, and we might both say great. But we might both mean something completely different by great, because our cultural experiences informed us as to what great development is. And so what we were looking at with postnatal depression, was looking at whether or not between the UK and India, whether cultural experiences were impacting what we meant when we said, oh, I'm depressed or I'm not depressed. And what we found was that individuals, mothers in India, although when you took the data, like raw data, you looked at it without doing any kind of cultural considerations, it looked like the prevalence of depression was much higher in the UK than it was in India. However, when you factored in, we used a method called anchoring video, which is, I won't go into detail on now because it would probably take another hour and a half. But basically use the method to try and understand how people were being influenced by those ratings. And then you can then quantify that bias and apply it to your results, pull out new results. And what we found was that it completely switched around. So actually, once you account for cultural bias, the prevalence of depression was much higher in India than it was in the UK. And we concluded that that may be because culturally it's not acceptable to talk about depression whilst you're pregnant in that setting. Or it may be that the level of adversity you experience in a low middle income country, our sample was a very low income sample as well, may actually mean that although you're feeling the same things as someone in the UK, you've got other problems which are more important, and so you minimize those feelings. And so if we were going to look at doing something again, maybe between the UK and South Africa in terms of this work, it would be really interesting to see if those same differences apply, but in terms of reporting about child development rather than reporting about your own mental health.
Questions? I think if we stop sharing, then it'll be easier to deal with. It's made no difference. Okay, I wanted to ask just a couple of questions about your study, which was really interesting. So first of all, maybe I may have missed it in the initial slides, what was your total population?
In terms of the FVSD study?
Yes, in terms of one of the three sites, the retrospective study.
The retrospective study. Yeah. So while the retrospective study with the FVSD sample, the sample was only 150, so it was a small sample. Although I think we had a cohort of 99 individuals with FVSD, which as far as I'm aware is the biggest cohort of that group that's been collected, which probably says more research in the area than anything else.
Okay. And then I suppose you mentioned that the participants had cognitive or intellectual impairment, but even for the older people, the parents completed the questionnaire. Mm-hmm. Okay. Yeah, so the questionnaire, so there's some limitations to what we did. So the questionnaire was aimed at individuals up to 18 years old, so young adults effectively. We kind of took the theoretical perspective that we know the sample is relatively impaired. So we felt the questionnaire was appropriate for that age, for older ages as well. We then also did look at the association between age and cognitive development, and we found there was no association. So it wasn't that the older children were scoring higher, children were scoring lower. It was fairly consistent across a very wide age range. Yeah. And then lastly, it was one of the things that we touched on yesterday. How did you cope with confounding by indication in the sample? Because if everyone's parents, mothers are epileptic, and they're only on something.
Yeah. So in terms of the FVS, this retrospective pilot, it's a very very crude analysis effectively. So we know, I think in terms of children diagnosed with FVSD, I think looking at controlling for confounding is dare say, a little less important because we know it's a real condition, and we know it has an impact. In terms of if we wanted to look at direct predictors of outcomes, then you'd obviously need a much bigger sample. And those studies have been done in populations of Valproate exposed children and looking at disease matched children. So looking at children who've been exposed to Valproate, carbamazepine, lamotrigine, so different medications. And again, you consistently see that even in a sample of women all with epilepsy, but on different medications, the children with Valproate are far and away more impaired than others.
Thanks very much.
Is that, so thanks, just as a follow on, is that even more than the fetal hydantoin syndrome and the phenytoin exposures? Because that also looks like quite a severe.
I think so. I can't say conclusively because I haven't looked too much at that population, but as far as I'm aware, the Valproate sample in terms of cognitive impairment and neurodevelopment is generally more severe than most other outcomes we've seen or exposures we've seen.
Just to follow up, a question around these tests. Are they very, if we were to use it in looking at HIV exposed, uninfected children, would it allow, have they found any value in using these tests in terms of providing care, any impact on that care, and early detection?
Yeah, so we know that the ages and stages questionnaire, particular, we've looked, that's been kind of had lots of sensitivity and specificity tests done on it. So we know it is sensitive to detect impairment. In the UK now, the ages and stages questionnaire is rolled out as a public health initiative. So all children, well, whether they do it or not, all children are supposed to have the ages and stages completed at various points during their postnatal period. Obviously, and then that is really just to inform the midwives and the healthcare team surrounding those children whether or not they're on track. So that if we know if you're below a certain cut point on the ages and stages questionnaire, then we know there's some potential developmental difficulties, and then that can inform the interventions that you then make. And again, if you make those interventions very early on, and it's relatively mild impairment, then you've got more of a chance of kind of correcting those trajectories as well as you can. Obviously, you can't in all cases, but.
Any questions online? All right, well, thank you very much. Thanks everyone for attending. And yeah, thanks a lot. Bye-bye.